We're here at HIMSS 2017, and we're talking population health with Arthur Kapoor. He's the president and CEO of HealthEC. Welcome, Arthur.
Thank you, John. It's a pleasure to be here.
Great. So you've been working on population health for a while, and to me, as a blogger, it almost seems like more of a buzzword that we've had forever, but we haven't seen much action. So, can you give some examples of why population health management is more than a buzzword?
I think population health management is, as you said, what's the word this month and what's going to be the next year. You're right. I think that probably is very correct. But I think population health has meanings very deep into the population as to how do you manage the populations. You have different subsets of data that come in, and where are you going to look for that particular data that's going to make you take care of your population better. I think population health management is probably a bigger word than what is being talked about today. It might change, but I think the bottom line still comes back is you're looking at how can you make sure that the patients, the people that you're looking after, you can provide them better care. And what are the IT words or IT markers you need to look at to make sure that they can fit the profile.
Interesting. So, do you have some customer examples of success where they've done some population health work and seen some success in their organization?
Yeah, we have several of them. We have a lot of patients, a lot of clients who came to us where, it was interesting that typically we install in systems where they have disparate data. So you have the claims data, you have the clinical data, you have other types of data, but they can't seem to bring all the data into one place. So when we get involved, it's mostly a challenge to say, I have my EMR data and it's in one place, and I have 43 EMRs, I have 675 physicians, and I have 4 payers, I have 14 hospitals, 6 HIEs, and 2 labs. So now you figure it out how you're going to do this. So the issue that comes back here is most of our clients have come back to us because they say that, listen, I have data sitting here. I have data sitting here. It's not that I don't have data. I have data. But can you make sure that this data can be the same data for this patient? So your EMPI, the electronic master patient index, has to be so accurate. Your algorithm has to be accurate. It is not the patient, which is a different patient on the clinical side. So most of our clients have come back and they've said one thing: implement these 43 EMRs in the shortest time possible and make sure that we can be a fully integrated clinically SIN, which is a clinically integrated network. So we have to take their financial data, we have to take their clinical data, match it, and give them results so that they can go back to the payers and ask for contracting values, which they were never getting before. So we have implemented that.
And that's powerful. And I like that you talked about the data because, I think we all know we would love to have all data. But, how much is enough data to get value out of it for this type of population health techniques?
Good question, John. I think to your to your answer, I think more and more data is required. We just finished a very large project where we were asked that, can you figure it out why for the Medicaid population that there was a addiction issue with opioid, and they wanted to know, is there any relevance to what data we are seeing, and can you do predictability on this? So we had to go back and it's gonna eventually, you will start looking at this and it's gonna happen. Population management cannot be done if you do not drive the patients to be engaged. The patients can only get engaged if you ask them questions which are all based on assessments. If your assessments can lead you to an answer, that's only when your algorithm will work. Algorithms will not work if I assign a value. Say, the new word, and I think it should come out soon, social determinants. And I'm sure you guys are hearing about it. So let's say I define and that a patient has access to transport. Now, does he have access to transport? Is there transport available? Can he get it? Now, you have to assign those numbers. So there's a value assigned to your answers. The question is, would a 4 meaning no transport access, 5 means access, right? Can you define what's the difference between a 4 and a 5, and can you define how that defines that person's purchasing power? Can he go to a doctor's office? Can he go to a pharmacy? Does he have access to housing? Housing is another issue. So when you start looking, you have to look at data from the housing. You have to look at the data from transport. You have to look at the buying patterns. So people sometimes go to a supermarket and they buy the wrong stuff. How is it interrelated? So when you say, is more data required? Yes, more data is required. Question is, we have not been able to manage the only recent one, whatever data we have so far. We have not been very successful at doing that. If we get more data, I think there'll be a deluge of data. So the question is, you need to set your parameters right and make sure that all your functional markers are correct, and then you can relate it to a patient. Why are they in that position at that point?
And that's the challenge with a lot of the approaches that I've seen from other organizations. They spend years gathering the data, and then they get all the data, and then they say, okay, now what? So I mean, how much time does it take to gather this data and get value? I think that's, at the end of the day, we need to get value out of it. It's not just aggregating the data for fun.
And that again is a challenge. So let's say you get a data. Now, first of all, a lot of times everybody says, listen, I can run your analytics and I can do your care. That is all good, but how do you prime the pump? Where's the data sitting? So the data has to come in from an electronic data warehouse. That's why the new thing now is you need to create electronic data warehouses, which is huge reams and reams of data. I mean, you're talking about a lot of data. But then how do you tag the data? How do you know? Think of it as a very practical solution right now, okay? I need to go to a server area, I need to go to a cage, I need to go to a data center, and I say, hold on a minute, I have X amount of servers in this cage, I have X amount of servers in this cage. Can I connect these two servers and make sure that whatever comes out makes sense? Similarly, think about this. You have tons of data sitting for different people, wherever in Medicaid, Medicare, payers separately. You have the claims data. Claims data is after now, 6 months after. Maybe you never found out. Clinical data is happening now. How do you take the claims data, marry it to the clinical data or to the EMR data, which most of the patients should go to a doctor, and if it's being recorded properly based on meaningful use, as you've seen, then you have that. Now, what happens? Did they refill the prescription? No. Well, what happened? Sometimes the pharmacies will not tell you. They say, yes, we received an order, but we don't know whether the prescription was picked up. Now you need the patient to, tell you whether it happened or not. So the biggest issues right now that we're seeing, and you asked about data again, comes back, social isolation. Most of the patients do not have access to care today because they live in isolation. When they're like that, they end up in the hospital because that's the only place which people are listening to. That's where you go, somebody's going to take care of you, right? So what do you do when you take all this data, which is all based on, and in fact, I'm speaking about this again, which is you take social data, social determinants, take it to the different, you have registries, you have Medicaid, you take the data from there, correlate it, make sure it's the same John Lynn, and it is not a different John Lynn, okay? If you can match it to 99.9 certainty, obviously you have a better algorithm that will work for your predictability. Only if you can predict what will happen is when you can take care of the patient. And most of the times, doctors don't even know that their own patients are having comorbidity, how many conditions they have, because they only know one. No, this guy has a diabetic issue. Well, he might be silent for 5 more issues. Where are they sitting? They're sitting in his EMR. But he doesn't remember that because he has to see more patients. What happens there? Bottom line, if you don't give access to the providers with all the data, they will never be able to decide the future course of action for the medicine.
So, I mean, some of this work is what you do at HealthEC. So what can you offer organizations today to make their life easier? Because they all know that they need to aggregate data and they need to get value from their data. What does HealthEC offer an organization to be able to do this, and where are you taking it in the future?
Again, a good question. I think I've always said that the proof in the pudding is we'll take your data. Within 3 to 6 weeks, we will combine all your data that we get, be it from the claims, be it from your EMR, be it from the labs, be it from the sure scripts or from the pharmacy. And we can combine the data, and we can tell you what is wrong with your population, what are the gaps in care, how do you take care of them, and have the whole care management built around it. Now, 3 to 6 weeks is not something which we say is, we just did it once. We do it time and again. And we take pride in it because our philosophy is we want to work together with all the people, be it the EMR vendors, be it the labs, be it the payers. And you would be, you probably know this better, that every payer probably has 10 payer systems of claims. Okay, so which claim system did I get it from? Okay, that itself is a big thing. EMR vendors, that's a point. Initially, they're resisting it because they don't want the information to flow out. Because remember, they have a control on this. So they're making it difficult for people to exchange information. But I think this has already come out, the new incoming administrator for CMS made an interesting statement that everything is good, but the EMRs need to offer information for other participants to exchange. And that's the right way. If you can do that and people can bring data across the subsets, it'll be much easier.
Well, I support your mission. My goal here at HIMSS 2017 is to find stuff that gets value out of the data. So thank you so much. We've been here with Arthur Kapoor. He's the president and CEO of HealthEC. Thank you.